everyone, and welcome back to Dr. Coco's Mnemonics. Today we're going to be going over some liver pathology, and these aren't mnemonics in this video, so I apologize in advance, but these are pictures that I hand drew and put different pathologies that I felt were high yield or that I'd seen on UWorld, Step 1, MB&Me questions, but I put them all into a picture that made more sense in my brain to put them and kind of organize them in a little bit easier way so that you can recall things when you do have a patient in front of you. So here I have a picture of the liver. We have the portal vein and hepatic artery down here. So this would be the portal system. And this is where you would have portal hypertension. So say you have a patient with liver cirrhosis, maybe a vascular obstruction, or schistosomiasis, which is one I always forget. It would be down here in this portal system, down underneath the liver, versus the top of the liver that would drain the liver into the IVC. This is where you're going to get Budd-Chiari, which is a central lobular congestion and necrosis. And so if you think about having some type of congestion or necrosis in this vein that would drain into the IVC, it would make sense that if you have a patient with Budd-Chiari, they would not have a jugular venous distension, because that's where the blood is coming from to go up into the jugular vein. And it would also make sense that if you cut this vein off, you're going to have a big liver. All of that blood's going to just be pooling right here, and it's going to cause an ascites and even a varices. And having those two pointed out and drawn like this really helped me kind of organize where is the problem in the liver and what's going to happen. So if you block this hepatic vein, your liver is going to get really big, full of blood, versus if you block the portal veins, the liver's not going to get big, and if anything, it's going to die because of lack of blood, and that would be more of a cirrhotic liver. And then we have these two over here, Wilson's disease and hemochromatosis. And for whatever reason, I always seem to get these mixed up. And I think a lot of it has to do with, is it something going in? Is it something that can't get out? Are we taking too much in? Are we not putting enough out? Whatever the situation is. So for Wilson's disease, this is where you have a bunch of copper in your liver, and you cannot get it out. You cannot excrete this copper out of your liver. And so this will show up with somebody that has those Kaiser-Fleischer rings in their eyes. So you have this buildup of copper in your liver, and it'll also cause neurological and psych issues. And something I found really cool, anytime you can put a situation into a story, it seems to help me a little bit better. So there was an episode of The Resident where this girl actually thought she had Huntington's disease. And so she had the chorea-like motions, but she was very young. And the doctor, of course, because it's television, was so brilliant, he found out from looking in her eyes that she actually had Wilson's disease. And maybe that'll help you, maybe it won't, but these neurologic and psychological symptoms can almost look like Huntington's disease with the chorea-like motions, but it's going to be somebody under 40 with this liver failure going on, and you would be able to see this Kaiser-Fleischer rings to help you figure out that this is a problem where you can't excrete the copper. So that's this X with the arrows going out. You can't get the copper out of your liver. And then we're going to look at hemochromatosis, and this is different because it's not that we can't get iron out, it's that our liver doesn't know that it has enough iron, and so it just keeps bringing more and more and more iron in. And so then you just absorb so much iron. And what's going to happen when you have a ton of iron? And the way I like to think of it is that iron has this pigment to it. It's going to cause you to be pigmented because you just keep bringing it in. And they like to call this bronze diabetes, and it's because you have this hyperpigmentation, but it also causes diabetes in these patients. And then you have all of this iron build up that would also cause issues in your heart, because the liver is so close draining into the heart. And so this is a problem where you just have too much iron coming in, right? That's what these little arrows are. They're coming in, not going out like in Wilson's. Another thing that you might get asked about is there's two patients. They both have this HLA-A3 hemochromatosis gene. And one's a brother and one's a sister. The brother had symptoms around the age 40-45, but the sister didn't have any symptoms until she was in her 60s. Well, why is that? Well, if you think about what's happening to women in their 50s and 60s, it would make perfect sense because she just started menopause. And when you have your period, you actually bleed out this excess iron that you have in hemochromatosis. So women who have hemochromatosis will actually have a later onset versus men that have it because they do not bleed every month to get rid of that excess iron. This is looking more at the specific, like zoom into the liver, what are we looking at? And so I have some things here labeled. We have the portal triad with the artery, vein, and bile duct. I put in the different zones. So you can see this on first aid where zone 1 has more of a toxin issue. Zone 2 is yellow fever, and zone 3 gets the least amount of oxygen in the central hepatic vein, so it'll get ischemia. And I put things on here like your stellate cells that normally store vitamin A, but if you have a fibrosis of these stellate cells, you're going to get liver cirrhosis. And drawing this out kind of helps me figure out what liver cirrhosis is, as far as like you're getting this fibrosis of these little stellate cells. I also put things like Kupffer cells, sinusoids, epithelial cells, things that you can look at whenever you want as far as structurally what it is. Then I put a little ER here, and this is supposed to help you remember alpha-1 antitrypsin deficiency. This is going to be misfolded proteins that get aggregated in the ER, and this will be a patient that is young, but they have what looks like emphysema and liver damage, and you're like, what the hell is going on? Well, they inherited this alpha-1 antitrypsin deficiency, and you'll have these PAS positive globules because of the amount of proteins aggregated in the ER. I also added a couple other things, not as high yield, stuff like cavernous hemangiomas, as far as like venous malformations in these portal triads, and steatosis. I've seen a lot of questions on this. I even had a friend send me one recently where they asked about a child who had taken aspirin after an infection, and then obviously they're hinting to you, this kid has Reye's syndrome, and then they're like, well, what's going on? And this is going to be a fatty liver problem, and so you're going to have this steatosis that's going to be in zone 3, and that's because of the lack of oxygen here, or the lower oxygen levels. And this could be in fatty livers, such as alcoholic fatty liver, but this could also be non-alcoholic or Reye's syndrome, where you have this steatosis in the zone 3. The last thing I kind of want to go over that, for whatever reason, really I struggled with for a while is jaundice. And I put this in yellow, and I hope you guys can read it okay. But here we have where you go from unconjugated to conjugated bilirubin through the UDP enzyme. And so if you have an increase in unconjugated bilirubin, it makes sense that like this is probably a hemolysis issue, right? You didn't get that conjugating pathway going on. So if you have a patient and they show like an increase unconjugated, you should definitely be thinking hemolysis, but you could also be thinking about Crigler-Najjar and Gilbert's disease. And these are a problem where you lack this UDP enzyme. And so that if you're lacking the enzyme, you can't make conjugated bilirubin. But also if you just have a hemolysis, your body's not going to be thinking, hey, let me conjugate this bilirubin. They're more worried about, hey, we're like lysing red blood cells. What the hell? Let's go like figure that out first, right? Versus if you have a ton of unconjugated bilirubin, you've gone through this process, but you're not getting that shit out. Like, you have an obstruction somewhere. And this could be primary sclerosing cholangitis, primary biliary cholangitis, which I can do a video on those later, and a good way to memorize those. This could also be Dubin-Johnson, where you have a dark liver, or Broder's, where you'll have a regular liver. But that would be something where you've conjugated it and then you can't get it out. And then lastly, if you just have an increase in total bilirubin, you're thinking, overall big term, this is a liver disease. Something's wrong with the liver. Not really sure what. Maybe it's a hepatitis. Maybe we have cirrhosis of the liver. But for some reason, jaundice kind of bothered me in my head, and it took me a while to understand. So I hope that this helps you guys out. And if any of these videos help you out, please like and subscribe to my channel. And if you have any questions or ideas of things that you need help with, just comment and let me know.